Hi, everybody. My name is Ryan Ackerman. I'm a paramedic practice educator in Vancouver, and I was asked to put together a little bit of information for everyone on the use of metered dose inhalers, or MDIs, for delivering respiratory medications during the current COVID-19 pandemic response. As we've probably all heard, there have been changes to the practice around nebulizing medications, and for some people, the use of MDIs is a new practice or something they haven't used quite a bit in their practice. So we're going to cover a bit of that today and give you all a little bit more information on how to use it. Okay, so first thing, if you haven't already done so, I'd highly encourage you to go to the BC handbook under the COVID-19 updates and take a look at the March 18th update. There's a really good written update on the restriction on nebulizing medications with their current COVID-19 pandemic. And there's also a great YouTube video from our Director of Professional Practice, Joe Acker, and he gives a very good explanation of some of the clinical rationale behind why we're making these changes. So rather than rehash all that through this video, I'm just going to focus on the practicalities of MDI use. So I'd really recommend you go and take a look at that now. So what's new? Well, if you saw the March 18th update, I'm sure by now you've heard that we're being asked to stop nebulizing medications in just about all circumstances. And really, that's just due to a risk of aerosolization. The same principle that allows us to use a nebulizer to aerosolize Ventolin or Atrovent deep into the lung tissue also allows those same droplets to bring virus and bacterial particles from deep within the lung tissue and put them out into the atmosphere. Now, for a number of years, we've been recommending to staff that full droplet precautions be used anytime you're aerosolizing or you're using a nebulized medication with an enclosed space like the back of an ambulance. But now we've taken the extra step of saying that under almost all circumstances, this practice needs to stop until the current pandemic has passed. So we've asked that staff start ordering salbutamol MDI inhalers for all stations. Some PCP stations will have seen these sort of showing up gradually over the past few months, but right now we're making this a standard practice province-wide, along with hopefully soon the aero chambers or spacers that will help make it an even more effective practice. So a couple of things I'm going to touch on today. First, the general use of MDIs and some best practice reminders. And in addition to this video format, there's also going to be a Medic Minutes podcast with Gord Miniker and Kayla Richardson. Both are UBC med students. Gord is a PCP with BCHS and Kayla is an RT. And they've got a great podcast that kind of goes over some of the high-level best practice uses. And this will just reinforce that with some visuals and some hands-on tips on how to use them with our devices, particularly with the aero chambers that are coming, with the CPAP masks that we already have, with our BVMs, and just a quick review of our treatment guidelines and dosing specific to this. But some of the general MDI practice things that we just really want to touch on is the fact that this may be a multi-dose device. In fact, the package will say up to 200 doses per puffer, but really it's a single patient use device, and that's never been more important than right now when we're trying to avoid cross-contamination between patients. Another piece that is really important is that even though for a space consideration, it would be easier to remove the canister and the blue actuator and just store them in your kit, it's really important that we keep them in the outer cardboard packaging until their first use. Not only does it prevent any damage to the nozzle on the actual canister itself, but it prevents anything clogging the canister or any contaminants that might be getting in there so that we don't cause any additional respiratory problems with the patients we're giving these to. So if you look at the cross section here on the right, there's a couple of things that I'll just draw your attention to. One is the canister itself, which is just the metal vial that holds the medication and the propellant and the metering dose valve at the bottom. And the other, which is just the blue actuator itself, which is what we would consider the puffer when it's contained with the canister and the little blue plastic piece. That's stored separately within the package and just has to be assembled when it comes out of the package. So as most of you have probably heard, you need to shake these things before you use them. They need to be shaken before each puff. So each single dose given, you need to shake it. And the reason for that is if you look into the center of the little blue piece, you'll see something called a retaining cup. Now, not all canisters are created the same, but the common theme with each of them is without shaking between each individual depression of the canister, there's no way to guarantee an adequate metered dose. So for every puff, we need to shake. Really important as well is that we need to prime it before the first use or anytime it's been sitting for more than a few weeks. Now, for our cases, we're only going to be using it once per patient. So before the first use, we need to prime it. Now, Gordon, Kayla's video, they recommend 4 times. I slip up later in a couple of videos and say 2 times, but the printed manufacturer instructions for the devices we're buying from Teva Pharmaceuticals say that it needs to be primed 3 times before each use. And here we have just a quick look at the AeroChamber Plus FlowView spacers that we're going to be supplying. They're going to be coming online on PDC very shortly. So these are only 2 of the various sizes that AeroChamber makes. They make a smaller pediatric size, which is good from sort of small infant up to about a year. The one on the right, the AeroChamber with the yellow with the little bear on it, is generally expected to be used from about 1 year to 5 years. And the one on the left can be used from about 5 years up. There's no real difference in how they work. It's just a sizing issue. So in a moment, I'm just going to show you a video from the manufacturer that goes over some of the key features a little bit better than I can, so you can stop hearing my voice for a moment.
Please follow these simple instructions when using AeroChamber Plus FlowView Chamber with mouthpiece for your inhaler medicine. The AeroChamber Plus FlowView Chamber can be used right out of the package. Before use, ensure you have read the instructions for the chamber and metered dose inhaler. First, look at the chamber and make sure it is not damaged. If it is damaged, replace it immediately. Remove the caps from the inhaler and the chamber. Shake the inhaler as per its provided instructions. Next, insert the inhaler into the back of your chamber. The AeroChamber Plus FlowView Chamber includes a flexible back piece that can be used with all commonly prescribed inhalers. Put the chamber mouthpiece in your mouth, closing your lips around it, forming a good seal. The FlowView inspiratory indicator only moves if you have a good mouthpiece seal. Breathe out gently through the chamber and then press the inhaler at the beginning of a slow inhalation as the FlowView inspiratory indicator moves towards you. The best way to breathe in your medicine is to take one long, slow, deep breath, followed by 5 to 10 seconds when you hold your breath. If you are not able to do this, keep your lips tight on the mouthpiece and breathe normally 2 to 3 times through the chamber after the inhaler is pressed. Slow down if you hear the whistle sound. It means you are inhaling too quickly. Only take 1 puff at a time. Follow the instructions supplied with your inhaler on how long to wait between puffs. If you have any questions, please ask your healthcare provider. For complete instructions, please refer to the patient instructions available on our website.
So I appreciate that that video was more from the patient perspective, but the principles still hold whether it's a patient it's self-administering or we're administering it as a paramedic. One of the really big advantages that these AeroChambers have is that if we're using the spacer and not just the puffer, we don't have to be quite as accurate with our timing of the delivery of the depression of the canister. Depressing the canister into the chamber, it's a one-way valve. If they haven't exactly timed their exhalation, they're not going to blow the medication out of the canister. And likewise, if they're not breathing in exactly when we depress the canister, they're still going to be able to get a good breath. It's really important that we remember that, under ideal circumstances, we're going to be having the patient exhale fully, depress the canister at the start of their inhalation, take a long, slow breath without activating the alarm whistle, and then hold that for 5 to 10 seconds and then slowly exhale. Most of you can probably picture the majority of your asthma or COPD exacerbation patients who are breathing too fast and too shallow to be able to coach them to do that. The spacer gives us the option to allow them to take several small, slow breaths and still get the bulk of the dosing. Whereas with a single puff through the blue actuator that comes along with it, and not the spacer, you're not going to get the same level of medication delivery. Okay, so I just wanted to give you guys a really quick update, a bit of a refresher on how to use the MDI with the Rescuer 2 compact CPAP device. As you'll see here, the MDI port is this little capped red piece here.
And most people, when they put the device on, they'll have the oxygen tubing hanging down. But what that does is it puts the MDI port facing down, which makes it a lot more difficult to deliver a proper dose of medication. So if you want to MDI into it, it's important that you just spin it around so that the cap is up on the top. All right. So it's on the patient's face. It's running at whatever CPAP setting you have it set at. Your manometer's here gauging your PEEP settings. And we're going to try and give a dose of MDI medication. So MDI comes out of the package. It's still got the blue actuator on there. We don't need that, but we are going to, if this is the first time it's come out of the package, we're going to prime it twice before we give it. A couple of good shakes before we give it. Doesn't really lose a seal if you take the red cap off. We don't want to leave it off for too long. So what we're going to do is we're going to watch the patient's breath. We're going to coach with them. Using the manometer, sometimes you can help see where their peak expiratory phase is. When they get to peak expiratory phase, just instruct them to take a deep breath in and hold. And as they take a deep breath in, give a dose of medication. All right. Have to shake in between each puff. On the next good breath, if they need a break in between, that's fine. Instruct them again, deep breath in and hold. And we'll do that 4 times in total, and that equals 1 dose, or 400 micrograms. And we can repeat that dosing every 3 to 5 minutes for as many as we need to, unless they start to show improvement or signs of toxicity, shaking, tremors, tachycardia, etc. All right? Much easier than TP's nebulizer, and much safer in terms of not producing any type of aerosolization of virus particles. Okay.
Just to add a little bit and maybe reinforce a few things in that video. First of all, as you probably noticed, I recommended that you prime the canister twice prior to the first administration. That's a mistake. It actually needs to be primed 3 times, or 4 wouldn't even hurt. Second is just remember that this is a slow process. This isn't something we're going to be able to get the full dose of MDI salbutamol in really rapidly. There's some literature that suggests you might need to wait even up to 30 seconds between each depression of the canister to allow it to fully repressurize. And if you're trying to coach a patient who's already short of breath to alter their breathing pattern, it's important not to try and force or rush that process. Right? We're just trying to slowly deliver this medication as effectively as we can. So sometimes it could take up to 2 minutes just to get one sort of full 4-puff dose into the patient, and that's okay. We don't need to rush that.
So I just wanted to give a really quick recap on how to use an MDI with the CareStream BVMs that we keep in our kit. All the adult, pediatric, and infant BVMs we carry all have a white MDI port just before the exhalation port. The challenge that a lot of people run into is that they like to put their bacterial viral filter in line between the mask and the BVM. If you were to insert MDI into the side there, your filter would actually filter out your drug before it reaches the patient. So we've got to move the filter. And in most cases, we would simply move it over to the exhaust port. You just need to flip it over the backside there. And as long as you've got a good seal or you've got an eye gel in place, any exhaled air will come up through the mask, out through the exhaust port, and will still be filtered. Although in most cases right now, if you're going to be BVMing anyone, you should really consider that you should be in full PPE for airborne and droplet precautions. Okay. So the technique is actually fairly simple. New MDI out of the package, shake it, prime it, shake it, prime it. And then this is the tough part, is it's going to be probably a 2-person job. We've got to wait until just before the person bagging is about to deliver a breath, and on their breath, we're going to give a dose of drug. We're going to shake again, give another dose. Timing every time with the inhaled breath. Much easier to do with an advanced airway in place than with the BVM, but it's still effective with a mask. Okay, 4 doses equals 400 micrograms, and that's going to be, 4 puffs equals 400 micrograms, and that's going to be 1 dose. And we can repeat that as many times as we need to effect, or until they reach toxicity. Okay, one of the other challenges that we have with this, though, is a lot of these patients, we'd like to put PEEP on a number of patients that we're bagging. The PEEP valve doesn't fit onto the bacterial viral filter in this position. So there's a few options for the ALS community. Most of the cars carry spacers with an MDI attachment that can go in line here. But for most people, what we're going to have to do is we either make the decision that we're putting the filter on here, or we're leaving the PEEP valve on here.
Okay, so for those of you who've taken the continuing professional development course over the past year, you'll have seen this and I've gone over, but just a quick reminder of our MDI salbutamol dosing guidelines. For adults, we're going to be giving 4 puffs of 100 micrograms each as a single dose, so 400 micrograms per dose, and we can repeat that as needed. There is no maximum upper dose, but we do want to watch for any signs of toxicity, which in the adult population would be, say, a heart rate over about 150, excessive tremors, or any kind of hemodynamically unstable dysrhythmias. In the pediatric population, we're looking at slightly higher doses. So in the under 20 kilo age group, we're going to look at 5 puffs. So 500 micrograms is going to be equal to 1 dose, and we can repeat that up to 3 times. In the greater than 20 kilo range, we're actually going to be giving 10 puffs at 100 micrograms each, or 1,000 micrograms per dose, and we can repeat that up to 3 doses. Under 10 kilos, it's actually not indicated, and the big reason for that is that there's not a lot of evidence that under 10 kilograms, children have much in the way of bronchial beta receptors. Most of their wheezing is typically due to mucus or other factors, so it's typically not very effective to be giving salbutamol in the under 10 kilo range. When it comes to ipratropium bromide or Atrovent, there's actually no dosing listed for MDI in our current treatment guidelines. A lot of this has been consensus over the past few days, trying to get experts together to decide. So the general consensus right now is that an approximate dose, single dose of 160 micrograms or 8 puffs is the most appropriate, and that can be interspersed with your Ventolin. It doesn't have to be given all back to back to back, but this is the prevailing wisdom, and you may see some changes, so keep an eye on the treatment guidelines as we go forward. Okay, I just want to thank everyone for taking the time to watch and listen. I hope that you found the information in here useful or at least informative. And I appreciate that there are going to be lots of other questions that come up as time goes on and we move into practice. And there are a number of different avenues for that. One of them is the clinical practice at bcehs.ca email, and that goes directly to the Paramedic Practice Leader Group if you have concerns or questions around best practices or changes to practice that might be needed. That's a great place to start. I'd also like to remind you that you all have access to paramedic practice educators across the province whose job it is to help with clinical questions, best practices, and those kind of things. And trying to find out who they are can be a little bit confusing. If you go into the BCEHS handbook under operations and contacts, you'll see contacts for both your paramedic practice leaders and your paramedic practice educators, and a bit of a description about what each does and their role. So in closing, I hope that everybody stays safe out there, and hope to see you out in the field.